Hello and welcome everyone to this small video on what emergency medicine residency in AIIMS New Delhi is like and what the branch in general is like for people who are thinking about joining this branch. So I got the idea for this video because recently somebody messaged me. He was apparently thinking about joining here, but he told me that there is literally no videos available on YouTube about what residency here is like and what the department here is like, etc., etc. So that got me thinking, and thought I decided that maybe it's a good idea to actually do a video on that. And I got some of my seniors to help me with this, for which I'm very grateful. And we decided to do this on National Emergency Medicine Day. So this is a nice day to do this kind of a video. So the whole idea behind this is that there are some very common questions that people ask when it comes to the course and the branch and life in AIIMS Delhi. So we'd like to look at those questions first, and after that we will have an audience round where people can ask us more general questions about things that they would like that weren't answered in the session before that. So before, basically it's going to be a question and a discussion kind of a video. So somebody is typing something. Okay, so we are basically having question and discussion type of video. So initially I would like the audience members to just refrain for a little bit while the prior AIIMS emergency medicine graduates discuss the questions first. And any doubts you can ask at the end for convenience sake. So this is like the most common question that I receive on social media about our branch, which is basically, I initially wanted to get general medicine, but my rank will basically give me emergency medicine. So the basic question is, will I be fulfilled with emergency medicine, or how similar are the two branches? Is it just the same? Is it just medicine and casualty? So I think Aravind sir, can you take the first question? This one, how similar is emergency medicine and general medicine, or how not similar are they?
Okay. Hi, Mal.
Hi, sir.
So, can you hear me?
Yes, sir, you're audible.
Yeah. Okay. I agree that this is a very commonly asked question. A lot of people end up taking emergency medicine with this mindset as well. So, see, ultimately, it depends on what you actually want from your PG. So, a person who is generally interested in general medicine is focused more on, I would say, the diagnostic aspect of it, the diagnostic challenges that come with it, learning medicine in a holistic point of view. That is what comes in the territory of generally medicine. And it's from there that you branch to different specialties like cardiology or pulmonology or nephrology or whatever it is. The problem here is when you go with that mindset to emergency medicine, it's completely different as to what you get in emergency medicine. In emergency medicine, your priority is not diagnostics. Your priority is treatment. Your priority is making an emergency diagnosis, which is very different from your final diagnosis, as you would say in final year MBBS, which is very different from your final diagnosis and the treatment of the condition, so that you can actually stabilize the patient. See, if a patient presents to you with let's say a patient presents to you with some any condition, say it's a COPD exacerbation or something, he has an emphysematous lungs, he presents to you with acute onset shortness of breath, and your priority there is diagnosing that tension pneumothorax and treating it. Your priority there is not diagnosing his emphysema or what causes emphysema, if it's genetic, if it's environmental, if it's otherwise, that's not all your priority. So for people who actually want that sort of diagnostics, that sort of follow-up, seeing a patient every day, seeing how the patient actually responds to the treatment from day 1 to day 7 of treatment, and, working up a diagnosis, like ruling out individual diagnoses one by one, and finally arriving at the diagnosis and getting that satisfaction from getting the diagnosis and treating the patient. If you are that sort of a person And that's why you want general medicine, then emergency medicine is not for you. In emergency medicine, if you're the sort of person who wants to see a patient at literally their worst and improve them as much as humanly possible by diagnosing their emergent condition which requires treatment and treating that, then emergency medicine is for you. So I think for general medicine, it's more of a diagnostics plus follow up, whereas in emergency medicine, it's more of immediate therapeutics and intervention. And diagnosis and follow up are extremely rare things in emergency medicine. There are very few conditions where you can actually make a diagnosis in the emergency itself. So if you need to evaluate what is the sort of thing which most probably you would have got from your internship when you go to different postings. You have an idea of what actually gives you happiness. So if that is the sort of thing that is working up a patient, coming to a diagnosis, treating them, observing them for a long time, seeing how they respond, be it inpatient or be it outpatient. If that's the sort of thing that gives you happiness, emergency medicine is definitely not for you. So I think that is the most important point to highlight as a difference. And second, coming to, is it medicine in a casualty? Definitely no. You get all sorts of things in an emergency. So it includes medicine, it includes surgery, it includes peds, it includes OBGYN, it includes trauma. Trauma is a huge component of emergency medicine. Then it can include literally anything, ophthalm, ENT, derma. So it can include literally anything that comes to you. So medicine in a casualty is definitely not emergency medicine. You need to be prepared. And there's one more thing that comes to your mind that I need to mention over here is your thought process when you see a patient in emergency medicine. While I was saying that diagnosis is not an important part in emergency medicine, your thought process, that is your initial spectrum of diagnosis, covers the entire thing. So while like a patient with abdominal pain or say epigastric pain comes to you, your thought process cannot stay at acute gastritis. You need to think of all the causes from say an MI to say a pancreatitis to if it's if it's say something like a pediatric patient or if it's an alcoholic patient, think of a Boraf syndrome or something. If it's a pediatric patient, probably think of intussusception. So there are a lot of things that have to go through your mind. So you have to cover the entire spectrum before you reach your diagnosis, and that too in a very limited amount of time, which is not the case with general medicine. So your approach, your diagnostics, your therapeutics, everything differs from medicine to general medicine. So I would say, from general medicine to emergency medicine. So my advice to anyone who has this query is think if the diagnostics and follow-up part of general medicine is what gives you happiness or what gave you happiness in internship. If that is the case, emergency medicine is not for you. So I think that covers the major parts of that question, ma'am.
Sir.
Mehul, am I audible?
Sir, you're audible. You're audible.
Okay.
So I think that was very, very well said, sir. So we'll move on to the next question. So I think so. Basically, this is another common question. So I heard that emergency medicine is a very hectic branch, and how do you balance family life post MD? And second question, you can add this as an. I wanted to add this question separately, but I forgot to add that. But what is the scope of women in emergency medicine? So is it a male dominated branch, or is it or is there a good scope for women also? So I think the best person to ask this is Akshay ma'am. Akshay ma'am, are we there? Akshay ma'am का connectivity which issue हो रहा? So Sreedevi ma'am, are you there?
Hi, Michael. Yeah.
Ma'am, can you answer this question?
So this thing, male dominated branch or not? Okay, I would definitely say that there is nothing like that. Okay, I've never ever felt that this branch is not for females. So I think yes, there is one place where I feel is when I get orthopedic patients, just the reductions and things like that. But never otherwise I've felt that this thing there is any gender bias this thing in emergency. And regarding this thing also the long hours, if you ask me, even Any other specialty also, they also have this long hours of practice. In emergency, actually, we have a fixed duty time rather than like 24 hours or 48 hours or ward duties. So I feel that a better work-life balance, we have it in emergency when compared to so many other clinical branches, be it medicine or surgery. So they have like their ward duties, they're on call almost for like 24 to 48 hours. Even after coming back from duty, you get calls. But in emergency, you don't have that issue at all. So you have only a fixed duty hour. Sorry?
Continue.
Yeah. So that question, I would like to say that there is like you need not think about anything like there is a male-dominated branch or female-dominated branch. It's absolutely there is nothing to do with that. So
Okay, Ben, I think that was well said. So basically, I would like to add that every branch is hectic. So medicine is hectic, surgery is hectic, gynae is hectic, pediatrics is hectic. Even my friends in the other branches like pathology, lab medicine, micro, they're all have feeling that it is very hectic. So every branch is hectic in one way or another. So I, if you compare, it's okay, man. So compared to the other branches, good thing about our branch is that we have fixed duty hours. So that does reduce a load a little bit, but it kind of spreads the load out because it's not like the first year residents will be overworked and it comes a little less in the other years. More like equalized out in the whole 3 years compared to the other branches. But in general, I don't feel that it is as worse that you might have felt before you actually joined the branch.
Hello, Mehul. Can I pitch in? It's Pradeeban here. Hello. Hello, Mehul. It's Pradeeban here from Sreedevi's number only. Okay.
Sir, you're audible. Please continue.
Yeah. I just want to pitch in this aspect regarding the hecticness. So, like you said, whichever branch you want to choose, it is going to become hectic. Whether you have work or not, it all depends on your smartness on how you go about the duties. Even if you have no work at all, you can make it your job to make it hectic all throughout the while. And even if you have loads and loads of job, you can make it not hectic at all. It all depends on your smartness. It all depends on how much you let it get to you. That's what I would depend. Because most of the time, what happens is rather than a physical burnout, it is a mental burnout at the end of the shift. What happens to us? So it all happens because we let that emotions get to us. So once we don't let it get to us, I think we are clear of that path. That's what I would suggest.
Sir, definitely. I think the main load on us is more mental compared to physical. If you look at the other badges, so even if our duty hours are less, the cognitive load, the mental stress that we take in those few hours is much more than the other badges sometimes. We'll quickly move on to the next question. So I think Pradeeban sir, you can take this question. So this is the opposite of the first question. So somebody is liking surgical branches more than medical branches. So he or she is wondering whether emergency medicine would be a good fit for me.
So coming to surgical branches, in this aspect, emergency medicine involves procedures like surgery, but not the in-depth one. So for all the people like me who don't have much of patience standing for a long time, just staring at something and doing something, here you can do all the procedures within a short span of time and do multiple procedures. That's what I would suggest. So yeah, if you are into procedures much also, you can choose emergency medicine. But if you are a core fan of surgery, like you want to do everything, I don't think emergency medicine is in that line of aspect. It varies a bit.
Yes, sir, I agree with that. So one thing that people might find interesting is that our branch, the mentality of the emergency physician is not that different from that of a surgeon. So surgeon, they'll basically care if whether I can operate on this case right now or not. So emergency medicine is like that. Only thing we see is whether there is an emergency condition right now or not. If there isn't, then we lose the interest very, very quickly. So that is kind of similar to the mentality of a surgeon. But other than that, if you are really into the surgical aspect of things, then this is probably not the right branch to do that. So this was a question that I wanted to ask Akhil sir or Vinayak sir, but they are not here right now. So Aravind sir, what are some thoughts on private practice after MD emergency medicine? So basically, what is the scope? Like people want to start their own hospital. So what are the options for that? What is the market for that? Basically, people were asking.
Yeah, see, there's two ways of looking at this. First is that obviously you have a see, emergency medicine ceases to become a standalone specialty in the sense that our job is mainly to stabilize the patient. A sick or a dying patient comes to you. Your job is to stabilize the patient and then move the patient on to definitive care. Now, there are lots of medical cases in which we ourselves can handle the patient at least up to discharge, not the long-term follow-up. But at the same time, like patients requiring urgent surgical intervention and all that, you may not be able to do that. You may not be able. So, emergency medicine, as say, is not some per se is not something that you can, open a clinic at home, have a regular OP follow-up visits of patients. That is not going to happen in emergency medicine. On the other side of it, there are lots of hospitals that are coming up right now with either emergency medicines that are not departments that are not there at present or departments that have just been initiated. So there is a large market for emergency physicians right now. This has obviously been affected a little bit by the NMC ruling of recent, but then that is obviously, something that could change in the coming years also. So what happens is with this large market, you have lots of places where you can actually even start the department at your institution and then watch it grow or lead its growth. And people are understanding slowly that emergency, just to add a little bit to the questions that were raised earlier, emergency medicine is not a substitute for another branch, or another branch cannot substitute emergency medicine. It's a whole different specialty in itself. So it's not like you wanted medicine, so you didn't get it, so you take emergency medicine. Or you wanted surgery, you didn't get it, so you take emergency medicine. It's a whole different specialty in itself. So what happens over there is and multiple institutions and private hospitals are actually realizing this now. So you can find emergency departments actually cropping up in lots of institutions now, where they actually want genuine MD emergency medicine physicians, MD or DND emergency medicine physicians are the ones who are actually wanted over there. So that makes it a very expanding job market, which I believe negates your need for actually starting a private practice on your own, which is very difficult if you're an emergency medicine physician. So these are the two aspects of the two sides of the coin, I would say. Think about it and make your decision wisely. Does that cover the question, Mel?
Sir, that covers everything. And anytime you're starting your own hospital, there comes a lot of stress and very difficult to break even.
Exactly.
Um,
Exactly, yeah. It's not as easy as everyone says, just starting your clinic or starting your OP practice, especially in this environment where almost all medical branches, I would say, are actually saturated. So in this era of saturation, to actually create your own niche is not as easy as in the olden eras where you were an MBBS doctor and you would actually have the entire community coming to you. So it's not as easy as that. So that is also a thing that should be taken into consideration when considering the possibility of private practice, I would say.
Okay, sir.
Can I add something here?
Ma'am.
Not that I have much experience in this, but I just wanted to share because it was the question about private practice after MD. One of my our seniors, basically Sandeep sir, he started his own acute care center in the Northeast. And while I'm saying it simply in one sentence, it involved a lot of effort, investment, and a lot of hard work to open an acute care center enough to Like he has his own ultrasound machine, he does the scan, he has a referral center. It takes a lot of effort to set it up, because not only are you setting up your own acute care center or urgent care center, you also have to have a referral. Like Aravind had mentioned, you can't just have like you diagnose a surgical problem if you don't have the capacity to treat. What do you do? So your acute care center, if you choose to do it as your private practice after MD, which is possible because he is doing it, but it's not easy. You can have your acute care center because as an emergency physician, you tend to learn how to do the first 15 minutes of any specialty. So you have the capacity and the knowledge and the skills to do it. But in the background, you also need to know, in case it goes beyond your capacity to treat it to its completion, then you need to have a backup to send the patient somewhere, like a referral center. If you have a tie-up with big hospitals or multi-specialty hospitals saying you will be an acute care center, and if there is a case that requires their input, then you will be referring them to that hospital and they will take those patients. So that being the case is your biggest problem. I mean, it's not your biggest problem, it's one of the biggest problems considering the investment into setting up your own acute care center. But for the future, that is an option. And if you have the interest and effort to invest into it, then you should definitely try. But it is an option. I just wanted to keep that.
Definitely. But I think the bottom line is that this is something that needs a lot of dedication, and you have to put your heart and soul into this if you are seriously planning on doing it.
Yes, definitely. And sir did do everything possible, so I can see how much he had to put in to make it happen. So it's definitely not an easy path.
Yes. So this was an interesting question. So I want to be a diagnostic wizard like a Dr. House. So some people and a lot of MBBS students also, everybody watches House. So they want to be like him. So they're wondering, they have this particular person, he has some interest in emergency medicine, but he says he also wants to become Dr. House. So he's wondering whether this is a branch for him. So whether he's basically he knows that, okay, it's not a diagnostic branch, but is there enough diagnostic things in here to keep him satisfy his interest in making there some kind of smart diagnosis, etc. So I think Srikanth sir, are you there? I think you can take this one.
Hi, Mehul, am I audible?
Sir, you're audible.
Yeah, I strongly feel that everyone who's practicing emergency medicine should have a great, passion for it. And if it involves you thinking about it as like Dr. House, not just managing the acute resuscitation. Basically, acute resuscitation is extremely important in emergency medicine because you're creating time for you to go ahead and think about taking a detailed history and then thinking about what the actual diagnosis is. So that should be the way medicine is practiced as a whole. You must create time for yourself and for the patient so the patient survives and you rule out any major diagnosis before you come to a definitive diagnostic. So I feel like this thought process has to be there in the back of your mind, and you do end up finding the actual diagnosis. I mean, you make a provisional diagnosis, which most of the times ends up being correct. I mean, you're not going to be accurate in the way that you might not know which organism is causing what and all. But most of the times, the differentials that you make in the emergency is more or less the same diagnosis that you come up with inside the ICU or once the patient is admitted. So I feel like this diagnostic satisfaction that you get is actually quite good in emergency medicine itself.
Sir, I feel things like this is very relative. So I think it is different for each person. Aravind,
Can
sir,
I
you want to say that?
add something over there? I'm sorry, just chipping in over there.
Sir.
Just to say, like this whole fascination with how all these medical series, that's not how real world medicine actually works. So even if you end up taking medicine like a general medicine, thinking you want to be a Dr. House, it's really not the way, once you enter clinical practice out actually works. And you would have seen that in internship as well. So like Srikanth sir said, the fascination of making a closer list of differential diagnosis and provisional diagnosis in the emergency medicine itself, it's pretty intense. So then looking for the otherworldly diagnosis, happens maybe once in 1,000, 2,000 cases or something. So that is one more thing that aspirants have to keep in mind, because medicine is not what is, at least medicine in India is definitely not what is shown in house. So just wanted to
Yeah,
put that out there.
you're not going to obviously diagnose any rare genetic syndrome that is not. I mean,
Yeah,
that's
that's
not going to
definitely
happen.
not
But
there in emergency.
I mean, the diagnosis that the patient has, you will end up coming up with, because that's usually the most common things that you see
Yeah,
in real world practice.
agreed.
So the actual
Definitely.
diagnosis that the patient has, most of the times you'll end up diagnosing them in the emergency itself. You don't have to, go for rare tests that usually never come up to be the diagnosis, even after admission or in any other branch.
Agreed. Yeah. Yeah. That's all.
So I agree. I think these things are relative, because I feel there's something that we diagnose like really fast and really amazingly. Like patient with cardiac tamponade, we diagnose it with focus like so much faster than anywhere else in the country, probably. For the patients presenting to the ED, we diagnose the aortic dissection very fast. So it does happen, not every day. So these things do happen, but it's not we are not going after these rare things like our senior said. So those kind of things take weeks, maybe months to actually come to a diagnosis. Obviously, those are not things that you are going to diagnose it one or 2 days in the emergency department. So I think these things are relative. We diagnosed emergent life-threatening conditions. I find a lot of joy and fascination with that. So uh, perhaps you might do as well. For people who are really into the diagnosing the weird, rare, autoimmune things, then this is probably not the branch for
Can I just add something here?
Anand.
So, two things. One about the TV show's depiction of what a specialty should be. Unfortunately for us, we're in India and they're in the US most of the time. So the description is by far like misleading, I would say, to the least. And so while it sounds amazing to have a made-up department like diagnostic medicine, like House does, I wish that were true. And or how in Grey's Anatomy, all the surgeon seems to know all the medical terms, like what nonsense. Which surgeon knows all the medical terms? They don't. Let's be very frank here. If there's an ECG change, they're going to be like anesthesia, something's happening. So let's be very frank here. That's not going to happen in real life, and it's definitely not in our country. But I would say if you want like an accurate description of what emergency medicine looks like, I would suggest the show Hospital Playlist. That being one side of the matter, like it is by far, like I've seen a lot of medical shows, it is by far one of the most realistic descriptions of what an emergency physician does. And second
Yeah.
side of the thing about being a diagnostic wizard. So like Mehul said, it is definitely something that an emergency physician knows that for a single problem, you have 5 different possible answers to a question that the patient comes with more than any other physician, because you can't think on one line and come up with how to save the patient. So you might not, since the diagnosis of like, I don't know, adult onset Still's disease, like a medicine person would, which takes some time and a lot of evaluation, but it would be there in your differential when they present. And you would rule out the most life-threatening causes because that is your job. It's not because you're not smart enough to think of the rare diagnosis. You know that the rare diagnosis is not what is going to kill the patient immediately. So you might not be the person making the diagnosis, but you will be the person who gives the patient a chance to live to make that diagnosis. Just that's all I would like to say.
Yes, man, that is very perfectly said. Our main job is to keep the patient alive long enough so that they can actually get a diagnosis done. So next one, I heard the emergency is really scary, and I'm not sure if I have the mental toughness to become competent as this. So Pradeeban sir, you want to take this question? Pradeeban sir is here.
Yeah, I'm here. Just a second. I'm just reading the question now. Wait.
So basically, they're wondering whether they can have the mental toughness, or whether this toughness should be present before they actually join MD, or whether it is something that you develop during the actual course.
So you are asking the wrong person here actually. I am a person who is ready for anything actually. Whatever situation is thrown at me, I am usually ready for those things. So I think this question should be asked to a person who were scared and became tough later on.
Okay, so I think I will respond. See, because when I was in third year MBBS, fourth year MBBS, if somebody told me that my future will be emergency medicine, I would not believe it because I was very scared of emergencies. So I was afraid of making mistakes. I was afraid of making any mistake that would end up killing someone. So slowly got over that. In internship, you got over that a little bit. You start seeing patients. You start working and taking care of some emergency patients. So I started to like that, and that is why I actually joined this branch. I had other options, but I wanted this branch because I felt that some connection with it. And then in first 6 months, definitely it was scary. I had this language issue as well because I didn't know the language very well when I came here. So all of that was a huge learning curve. So all of those things are scary as well. It's not just about the patient. If you're going to a different brand new state in a different part of the country, that can also be quite scary. But mental toughness, I feel that it's something that will come with time. So if you're asked to take care about around six sick patients when you are in a second semester of your course, and you will find it very difficult. But after some time, you will build up the mental toughness so that you can even see 12 patients, and you will know how to manage 12 patients. So you'll know what all are the key things that you need to do to keep the maximum amount of people alive. So that toughness will come when you become more competent, when you become a little bit more confident in your skills and your abilities. So I feel that anybody can do any branch, and there's no fixed this thing quality that you should have before you actually join the branch for you to become successful. So maybe sometimes you do have some qualities that make things easier, but it's not really a prerequisite per se. As at least that's what I feel. So unless anybody have anything else to add, I think I will move on to the next question. So I have plans to go abroad after MD. So US, UK, Australia, etc. So is this a good branch to take if I am planning to go outside the country long term? So Aravind sir, I think you had some plans to go to UK at one point of time, I think. So do you want to take this question? Aravind sir, are you there?
Mehul, can you hear me?
Sorry, I can hear you.
Yeah, okay. First off, correction. No, I didn't have a plan to go to UK. So I just wanted to correct that. But yeah, talking in general about the opportunities outside for emergency medicine, yes, they are very much prominent outside India. As a general statement, I would say that acceptability towards emergency medicine is much more outside India than inside India. So that is one statement I would like to make over here. It also depends on what you want. So, for example, one of our seniors is actually doing an emergency medicine residency program currently in the US. So she is, while I've corresponded with her, she has actually told me that the academic program over there is covers so much. Like it's different from India definitely, but it covers so much vastly, and you have the same pleasure of actually seeing patients their worst and trying to resuscitate them and everything. And the respect for an emergency medicine physician is also much different outside India as compared to India. The other thing that I would like to highlight is, well, there are three predominant brackets that are considered, that I would say, which is obviously the US, where you have the MLE pathway, and then you have the UK with the where you go via the MRChem, FRChem pathway is the one that is commonly taken. The others also go via the PLAB pathway right after internship. That is something that you can do as well. Whereas if you have finished residency, it's preferable to go via the MRChem, FRChem pathway. And then the other bracket is usually considered Australia, right? So where you have the AC exams, so ACEM exams actually, sorry. So now all three of their pathways have their pros and cons, which I think will be a topic in detail for another day. But the point is, yes, emergency medicine, there is a demand for emergency physicians in all of these places, actually. In the US, it is still a little bit difficult to get matched for an foreign medical graduate into the top colleges. Whereas in the Australia, when like what I know latest is that there is actually a huge demand over there for emergency as well as critical care physicians. And it covers New Zealand also. The work-life balance conditions there are actually much better than what is sorted out in India. So yes, if you are looking to move abroad, emergency medicine is definitely one specialty you could consider, and one you could see the demand increasing in the foreseeable future. The reason for that is probably a drawback of emergency medicine, which I hope we'll be discussing later on over here. So we'll see what that is.
Yeah.
I'll hand it over to you, man.
But one disadvantage will be, going to residency again in another country. So some people do that, but I'm not a big fan of that kind of pathway. So we'll move on to the next question. So this is a general question. My college doesn't have an emergency medicine department. So how is it different from the casualties we do here? So Sreedevi, ma'am, you want to take this question?
Am I audible?
Ma'am.
Yeah, okay. So my college also didn't have a emergency medicine department. So we had only a casualty there. So the difference is, like in a casualty, a patient comes, the patient is having a chest pain. We immediately make the medicine ICU paper and then we shift the patient to the ICU. Same like that, a patient is having an acute abdomen. We immediately shift the patient to a surgical ICU. So that's what I think. Only what thing I knew in casualty was just to see which department the patient will go to, and then shift the patient to that department. So that's what we used to do in the casualty. So in the Department of Emergency Medicine, so what we do is we actually treat those patients first, and then after stabilization, if they need care or admission, then we shift the patient to the respective wards. For example, the same thing. If the patient is coming with a chest pain, so like if the patient is you take the ECG, you first diagnose it there itself. And in case if the patient needs to be shifted for PCA, you immediately shift, or otherwise, if you need to thrombolyze, you do it there. Or if the patient is having an acute heart failure, you actually manage the acute heart failure there instead of sending it to a cardiac ICU. Or if the patient is having an acute abdomen, you actually try to first diagnose it or treat those things. So I think that is the main difference. So the patient is there with you for example, in our emergency and all, we know that the patient is there with us for at least like 24 hours. They get their admission only after a day or two. So till that time, those patients who need a very acute care, so they are with us and we are managing those patients. And most of the time, sometimes, for example, if the patient is having a hypertensive heart failure or scape or etc., so we actually treat the patient, and sometimes the patient get discharged from emergency itself. So they come with a very acute situation, and then we treat them, and they can sometimes, most of the time, be discharged itself from the emergency department. So I think that is the main difference between a casualty and an emergency medicine department.
I would like to add upon here. So the thing is, it is not always black and white about the patients who come here. They fall into the gray area between. It is not like if a trauma patients come, they won't have any medical condition. A medical patient comes, he won't have a trauma condition. So where will you put that in a casualty case? You have to send to a respective department, and then again there will be a call over sent to the other respective department. They have to come. Here it is not like that. Here you are a person who are competent enough to manage, even if a trauma patient has an hyperkalemia or an acute MI also. That competency we develop by running an emergency medicine department. That is, you can manage any case in any spectrum who is coming in emergency.
Yes, sir, definitely. And the what you said, that like that gray area patients, those patients are the ones that actually do very poorly in hospitals which don't have an emergency department, because they'll be shifted. Oh, okay, patient has abdominal pain, but the medicine fellow doesn't think that it's a medical case. They'll shift it to the surgery team. They'll go and see. They don't feel it's a surgical case. They'll shift it back to the medical team. Patient gets sick. Patient deteriorates. Patient dies. Very common story, especially
Can I
because.
add one thing, Mehul?
And
Sir.
also, I think like when the patient comes, there are also situations where we feel that this is not an emergency. For example, like the patient might have some symptoms and they come to emergency. And also, we also need to diagnose whether it is an emergency or it is not an emergency, or the patient can just like be discharged as an OPD basis also. So that is also one thing I think that differs from like casualty to emergency medicine. So you need to actually first see whether actually there is an emergency issue or not. And I think it's a very bold decision to make that when a patient comes to emergency and you say that this is not an emergency, I think that's a very bold decision to make sometimes.
Mehul, sorry to interrupt, just wanted to add
Sir.
one thing.
Sir.
Yeah. So see, emergency has two very important components, and just to add to what Sreedevi said earlier, that is triage and resuscitation. And both of these are, I would say, like sciences in itself. They're not as simple as they seem to the, naked eye, I would say. So that I believe these two are key aspects where a casualty differs from an emergency department, where there is proper triage and proper resuscitation. Like Srikanth had said that, golden 15 minutes, the platinum 15 minutes and golden 1 hour. The resuscitation over there makes a huge difference to the patient. And I know as all of us graduates, we can actually, we have multiple evidences where we have actually seen that. So I think these are the two key areas where casualty differs from an emergency medicine and makes a huge difference in the patient's life.
Sir, definitely. I definitely 100% agree with that. So I think we'll quickly move on to the next question. So another very common question here. Recently, NMC has removed the rule that every medical college should have an emergency medicine department. So how will this affect our future prospects? So Akshaya ma'am, you want to take this question?
Yeah. So while it is true that the NMC has removed that it is no longer mandatory to set up an emergency medicine department in every college, I think, and I believe all of us will agree that it was a decision that was poorly made, considering that. See, the thing that happens with this is everyone thinks that another department person can just do the job that we are doing. For example, a medicine resident can just come to the casualty, attend to their patients, and go. And I'm calling it casualty because that is what it will be. It will be leading to a lot of casualties. So a surgeon will come and do this, an ortho will come and do this. That's how a casualty department in like in a normal medical college runs. Everyone has to come and take care of their own patient. Till then, they are what do I say? Depending on the blessings of the Lord or whatever it is, the force they believe in to stay alive and make it till then, while the nursing officers scramble to do something. So this is the reality of what happens on ground level zero, and it was made mandatory by the suggestions of a lot of experts in this country for that very purpose, so that any person has a chance to survive while being handled by people who are experts in the field. And I can tell you that much that this change in the rule is also being fought so that sense can prevail again. So while this is a temporary setback, I would definitely not say it's a permanent setback that our prospects in the future are ruined. And I believe in the private sector, especially, they are more likely to set up an emergency department anyway because they can hire locum professionals and to take care of their emergency patients more than bringing in other specialists to come to the emergency at all hours, and which is not very easy to happen unless they're assured of taking up the patient. So a private sector, especially, they would prefer having an emergency physician rather than having another specialist coming in for every patient that possibly requires their consultation. So while yes, this is a temporary setback, but I don't see it affecting the future prospects for a long term, because it's a matter of time before they realize that they repealed a very necessary rule. But it does require coordinated effort. Nothing in the government happens very easily. So let's be realistic about that. But like I said, it does not change the fact that it is a recognized specialty. And if you were to apply for a job, you as an emergency physician are much more likely to get it, because the people hiring you know that you are required, even if the NMC doesn't.
I think one of the problems here was that rule was brought in a little bit too quickly, and most places weren't actually prepared to actually start an emergency department. So it led
One
to
of the rules was that you can only have a department if you have someone who's already trained in emergency medicine as faculty, which is a counterintuitive rule, because how can you have someone trained unless the specialty exists? So it was like an impossible role to fill. So people were falling short. The NMC accreditation was falling down because of a rule that was impossible to enact
yes.
or implement. So yes, I agree that certain modifications are required, but it is not impossible, and it will definitely be, with some modifications, implemented in the near future, because people will be fighting for it. It's not something that's to be let go of.
Yes, man, definitely. So, what is the earning potential after MD? I think Aravind sir, you can take this question.
Yeah, coming to earning potential of after MD, yeah, this is, see, let's put it this way. Emergency physicians are in demand, so the salaries automatically go higher. This is the simple way of putting it across. Now, if you are comparing it to other specialties, like say, it's basically a supply demand component. So right now, as long as emergency physicians are in demand, the salaries are going to be high and much higher when you compare it to, say, a general medicine or a general surgery physician, because that's already saturated. Even there are some hospitals where even cardiologists probably earn less than emergency medicine, because cardiology is getting to be a saturated branch. There are this depends on the place where you're working, the hospital where you're working, the local conditions and everything. But as a whole, emergency medicine physicians do make a lot of money after MD, especially in the private setup. Now, one thing that I have to say is, when you are contemplating your salaries post MD, one important thing that you have to remember is, with every super specialization that you do, it automatically brings a hike in your salary. So that is one of the things that you have to keep in consideration, because for emergency medicine, the super specialization routes are definitely limited. So you have critical care, which a lot of emergency physicians do go into. So those who have followed the path of critical care do obviously get an even bigger hike in their salary components as compared to those who stay with just MD emergency medicine. So that is the same as in other branches as well, right? So if an endocrine specialist obviously earns way more than a medicine specialist, or a vitreoretinal surgeon earns way more than an ophthalmologist. So that sort of discrepancy obviously exists in emergency medicine as well. But right now, yes, with the demand for emergency medicine physicians, salaries are definitely higher than most contemporary MDs. That's what I wanted to add.
Okay. So we'll move on to the next one. So this is a common question that we get, and I don't think we can actually answer this question because, and I think somebody was asking in the chat box also about what the best colleges for MD medicine is. So we can only really talk about our department. So we are not qualified to talk about the quality of the cohorts in other colleges. But I think Akshay ma'am has also said that there are certain things that you have to, look for in a good emergency medicine department. One thing is that we should have faculty who are actually interested in emergency medicine. That is important. So in it shouldn't be that somebody has pushed them into this role just to create this department, to meet some guidelines. And there needs to be some facilities so that procedures and diagnostic can be done in the ED itself, like a focus machine. If you're not having a point of care ultrasound machine in the ED, then I think the potential of the branch itself becomes very, very limited. So those are few things that you have to look at in that particular college that you are seeing the department in before you actually choose the department. So
That is definitely true because, and I have to say now the advantage is that with so much online resource available, you can reach out on Twitter or get a contact through a WhatsApp group. It is definitely possible that you can find out about how the institute is that you are prospectively looking at. So you are not limited by what do I say, the lack of information that used to be the case even 10 years ago.
Yes, ma'am.
So please do find out. And most people, I'm not saying all, or I won't even say most. Many people do know or do have an idea of where they're going to be or where they want to be later. So if the setup you want to be in is going to be a setup which does not have, say, a focus machine, then you're fine enough in practicing in a place which does not have an ultrasound machine in the ED level. So take your preferences. If you're going to be like, I'm going back to this place or this is where I want to be, choose a place that will give you the resources or the teaching that you can practice in for your setup. So if you have a path like that, you can definitely make a clear, informed decision. And with the availability of online resources or how to reach out to some people, you can definitely find out if the institute that you're planning to look at is the right fit for you.
Yes, ma'am. Very nicely said. So always please do your homework on the colleges that you want to join. I think this is true for almost any college or any branch that you're actually planning on joining. You should actually learn about the department before you actually fix it. So this is one of the second last question. So options after MD, DM, fellowships, etc. Srikanth sir, you can take this question because you are doing DM right now, critical care. So please.
Yeah. Am I audible?
Yes, sir.
Yeah. So post MD, you have an option of doing DM or DRNB in critical care medicine. Other than that, you also have a few other options. For example, in institutions like AIIMS Raipur, you have DM pediatric emergency medicine and forensic, I mean, toxicology, medical toxicology, I believe it's called DM in medical toxicology. And as I think PGI Chandigarh, they're doing an DM acute care medicine. But these branches as such, other than critical care medicine, are not yet properly established. So we're not really sure as to how it will go. Pediatric emergency, especially, is in infancy stage right now, but there is a potential for growth. But since emergency medicine itself is in a initial stage, I mean, it might take a long time for I mean, branches like them to actually come up. So that is about DM. You can also do several fellowships. And I mean, the main fellowships I believe are pediatric emergency medicine. I think in AIIMS Jodhpur they're doing. What else? I mean, there is things like MRCM and all. Is there anything I'm missing, right?
No, sir. I think you covered most of the things. So basically, it's limited. It's limited to commit to some of the other branches. And thing about pediatric emergency fellowship is that, as you said, it's not very well developed. Me and Aravind sir had a conversation a few months back. So basically, the problem is that we are a budding branch and we are not very comfortable going into PEDS. Most of our faculty are not from a PEDS background. So that crossover hasn't really happened yet. So I have no idea about the pediatric fellowships. I'm not sure if anybody has a good idea about how they function. Please contribute. But I think it's a branch that it will take a long time to actually start developing. So as a fellowship also, it will take time to actually develop into something that is actually worth pursuing, I think. Critical care is definitely an option for people who want to progress from the ED to the ICU. So that is definitely an option. But the advantage, I think, is not in that there in the option. That the advantage is that emergency medicine is an end branch. So this is the branch where DM is not actually compulsory to survive compared to other branches, perhaps. So that is that could be something that I think a lot of people find appealing. So I think last question, I think Pradeeban sir can take this. How much exposure to trauma, orthopedics, or pediatrics can we expect during the course?
The ideal thing is we need to have adequate exposure in all the specialty, because like the first question you asked, emergency medicine is not medicine. So emergency can happen in any age group and in any sort of way. It can be a traumatic case. It can be a pediatric patient who is coming with a trauma. It can be combination of any of those things. You cannot just embark on or just hop onto a medicine to manage all the cases, whatever you can see. I think all the hospitals need to develop a robust system where all the residents get exposure in all these emergencies, not just a medical emergency. It is a sad state in emergency medicine AIIMS currently, where we are made to focus more on medical emergency compared to other things. But we need to have exposure in all the other things: trauma, orthopedics, pediatrics, everywhere.
So, though that's the end of all the questions. I think this was a very good discussion, and I think we discussed most of the points. Now, I will give it over to the audience to ask anything that we haven't covered so far that you would like to know about our branch and our course here, and we will try to answer it to the best of our ability. How many months of rotation in PEDS emergency? It depends on. See, the problem, what has happened is that COVID-19 happened, then all the structure of all the courses and all the branches got a little bit screwed a little bit, and then our peripheral postings got a hit. Now recently it started to come back because we have finally started to get more JRs. So we had a problem the past few years because we were having very few JRs. We have four batches, basically units in our department, and we are getting 2 JRs, 3 JRs, 2 JRs every round. So one batch will end up with having no JR for that session. Then it becomes difficult to actually manage the main emergency and to allow people to go for rotations. But now hopefully it will start increase again. It used to be around 2 months, I think. For Aravind sir, I think it was one. He was also affected by COVID, so I think he had
So the
some.
ideal posting was actually 1 month in PICU, 1 month in NICU, and around 1 to 2 months in pediatric emergency. So, and whatever cases you send to see the trauma ED, whatever pediatric cases you see in the trauma ED. So at least 4 to 5 months solid, you should be able to see pediatric cases if your posting order is as per what it used to be.
And ideally, I think 4 to 5 months are needed to actually become confident in beats. So it's not something that you can pick up in a few weeks or something. You need some good exposure, similar to trauma. Trauma also you need some minimum 5 to 6 months, and ideally much more than that. So
Yeah, I think trauma also used to be like that. It was trauma ED, trauma ICU, trauma radiology, minor OT posting for all the fracture setting as well as suturing and all of that. So some of them were 15 days, some of them were 1 month, 1 month. And so around 5 months, 5 to 6 months was the original plan. So if it goes back to that, where how normally things were, then this is what you should be getting.
So I think I will turn the recording off in case of people are too shy to speak in a recorded video. So I think we'll end the recorded session here.